Okay, so now that we have talked about the overall summary of what family systems theory is, talked about some techniques, and considered some clinical benefits and limitations, I'm going to talk about how we can actually take the ideas from this theory and apply it to our practice as SLPs. I'm going to take you through some examples of scenarios we might encounter, and then at the end, we're going to go through a case study and discuss that. So Asher describes the SLP's role in using the family systems theory framework as working with families to help them identify ways in which their behaviors impact communication difficulties. And this is in order to facilitate compliance with therapy tasks or management efforts and to remove conditions that maintain communication disorders or barriers to communication. And so, as we have all learned, families are an incredibly important part of the therapy process, and a lot of the practice happens in the home with families. And in order to maximize our individuals' treatment, we want to involve them as much as we can. So let's consider the applications in the context of having parents or caregivers implementing strategies at home, which is what we often see, especially with our younger clients. So the big question that we might all ask at some point in our practice is, why aren't the parents implementing the strategies at home? Why aren't they doing their home practice? I don't understand. So let's explore some reasons as to why that might happen and how we can respond to different scenarios. The why number one is that they are emotionally overwhelmed by their child's diagnosis. This is very reasonable. How do we respond? By attending to that emotion and making a point of telling the parent that their child can learn and improve, and that we can give them the tools to do so. Why number two, they don't understand who is supposed to do what or why it helps, it being the home practice that they have been assigned or recommended to do. And so how do we respond? We need to make sure that the parent knows that we are not abandoning them to do the intervention by themselves. We are still there to support them, and we are going to give them the tools in order to do the intervention. And we should always be checking in to see if they would like more resources or guidance in order to better implement home practice. Why number three, they have too much going on already and don't feel like they could possibly add something else. How do we respond? Work with the family to find a way to not add anything to their day, but supplement what they are already doing within their daily routines. So how can we build in home practice so that it's not a quote-unquote burden and doesn't disrupt their day, but still gets in that essential communication practice that we want for our clients? Why number four, the information is going over their head, it's too confusing, or it's way too much to remember. Sometimes we have the tendency to over-inform our parents just because we have so much knowledge to share, and we want them to feel like they have all the information at their disposal. But that is a lot of information, and they are not the professionals we are, and so they're not as familiar with the material. And so we need to assure them that they don't have to remember everything that we tell them, and that we should offer them handouts or videos so that they can reference those instead of relying on their memory. Why number four, they don't feel like we're relating to them or providing useful strategies. How do we respond? When parents feel misunderstood or judged, they are more likely to take feedback as criticism. So enter the therapeutic relationship with the family with an attitude of unconditional acceptance. Are you not sure what's working for the family? Then just ask them. Then you can actually make adjustments that will work better for them, the client, and the family overall. Okay, so now I'm going to talk about kind of a more, it's not really a theory, but it's a concept by Molly Schenker, and it's called shared decision making. And it does include a lot of concepts from the family systems theory. So there are 5 main steps to shared decision making. The first step is that the clinician clearly communicates to the family that there are treatment options and that a decision should be made regarding treatment. So this is clearly saying there are options, but you need to be able to pick an option. How do they pick an option? Step number 2, the clinician provides reassurance that they will support the family in learning about all the options that are provided to them. Step number 3, the clinician offers information about all these treatment options and helps the family to compare and contrast, providing clarification, resources, and answering questions along the way. Step number 4, the clinician encourages the family to discuss their treatment preferences, goals, what would work best for their family and their child or their loved one, and to give in all the information that was previously provided to them by you, the SLP. And then finally, have the clinician incorporate the family's preferences into the treatment decisions so that it is a shared, mutual conclusion that they've made. There are some things we really want to keep in mind when we're working with families, and so I've kind of highlighted some things to remember. Number 1, parents have to make a ton of decisions about their children, especially if their child has communication disorders, other comorbidities, or other physical disabilities. And so we want to make sure that we're making the process easier and not more confusing or difficult. Number 2 is pretty simple. Meet the families where they're at. Don't ask too much of them, and don't expect too little of them, as that can kind of seem condescending. So meet families exactly where they are, see them as the whole unit that they are, as discussed in the family systems theory in the beginning of this presentation. Number 3, cultural humility is a critical factor. We need to take into account all the cultural aspects having to do with this family and make sure that our treatment adequately reflects the family's wishes. Number 4, families may have overcome systemic barriers to get services. Oftentimes, healthcare can be riddled with racism and classism and all the things that we've learned about in our previous DLD courses. And so we need to recognize that they probably have worked, or they may have worked really hard just to get to see us. Number 5, emphasize the family's expertise and priorities as part of the decision-making process. Recognize that the family often knows what is best for the child and know their child best, and we need to take that point of view into account. So let's put all of these ideas together, and we're going to talk about a case study. So I will read this and think about, as I read along, how you might respond to this family and address their concerns for treatment. It is your first day of treatment with a 5-year-old young Black girl who has recently had a diagnosis of autism spectrum disorder. She arrives to the clinic with her mom, dad, and her 6-year-old brother, who has an expressive and receptive language disorder and a congenital heart condition that has him in and out of the hospital often. The family arrives 10 minutes late, and the client is dysregulated due to the change in her regular schedule. The mom immediately begins to soothe the client, and the father sits at the table with their son quietly waiting for the mom to join them, as she knows more about the client's history. 5 minutes later, the mom joins, and she begins to describe a busy household that includes many doctor and therapy appointments. They have a large family, and the client's aunt and grandmother live with them and are always eager to help out with the children. She explains they are familiar with speech and language therapy, as their son has been in services for 2 years now. She knows how beneficial therapy is, but expresses that they are overwhelmed as a family to have another child that needs therapy. The dad begins to discuss that he works night shifts and only gets to see his children in the evening before he leaves for work, and that is when the family all has dinner together. The parents had to struggle to get their daughter an ASD diagnosis and were frequently dismissed by previous doctors. Now that they have a diagnosis, they are tired and worn out from all the effort, but still have a desire to help their child as best as they can. So pause the video if you would like to think about it a little longer, just kind of ruminate on all the details that were just read. So I'm not going to talk about all the things that we would address, but just highlight some things that I think were interesting, important, or necessary. So how do we use the concepts from the family systems theory and all that's been talked about in this presentation to address this family's concerns and their circumstances? So something that I think is important is to recognize the racism they may have experienced within the healthcare system and assure that you will work with them rather than against them, like previous healthcare professionals may have done. Then we want to partner with the family to find where home intervention can take place that will not add any unnecessary stress to their already busy family. So it sounds like the aunt and grandmother are eager to be involved with children, so maybe they can also share in implementing any home practice. And it sounds like that the time that the family gets to be together is dinner time. So maybe home practice can be incorporated into a mealtime routine, since dad can also participate in that one as well. And then we also need to understand how the parents' relative stress and emotions can affect their child and their progress. And so we need to constantly be aware of that and recognize that throughout the intervention and therapy treatment cycle. And then finally, we should understand the societal attitudes towards Black families, families who have individuals with ASD, and the combination of these two. As we've discussed in our ASD course, if you are in this course, oftentimes Black children with ASD will either be under or overdiagnosed due to preconceived notions and misconceptions about how quote-unquote Black people should behave. So we need to be aware of this and make sure that we are not perpetuating these ideas in the treatment room. Okay, that is the end of this presentation. Thank you so much for watching the 3-part series, and we hope that you learned a little something about working with families in therapy.